Good morning, and welcome to our first session, the Keynote panel. I'm really excited to have this group of panelists. It's going to be just a great hour, so I'm not going to delay very much in any kind of intro. But this is about how health IT can promote health equity. I think it goes without saying that one of the priorities for both the state, but also nationally, is making sure that we reduce disparities and provide kind of equal and open access to care so that all communities can be raised and achieve their highest level of health and wellness. And there's been a lot of important thought and policymaking and hard work going into doing just that. In many ways, Maryland is leading the charge across multiple dimensions. And so I'm really excited to have the group of folks we have on. We're going to go through, and each of them is going to make some opening remarks. And then we will open it up for audience questions. So please, as everyone's talking, don't hesitate to type into the comments and share your thoughts as we go. But first up, we have Joseline Pena-Melnyk. She is the new chair of the Health and Government Operations Committee in the Maryland General Assembly, House of Delegates. Chair Pena-Melnyk has done just remarkable things in her career, both before and in the legislature. I think first, I just need to say how thankful we are that she is a partner to CHRC. Both Delegate Pena-Melnyk and her predecessor, Chair Shane Pendergrass, really are the ones who led the charge in the General Assembly for a lot of the statutes that have allowed CHRC to thrive the way we have. They've been visionaries in terms of policymaking and just really supportive, not only of CHRC, but how CHRC fits into the broader ecosystem of healthcare. I'm always blown away by her ability to balance what I call them patients, but what her constituents are demanding of her, but also how that fits into a thriving healthcare ecosystem, both across hospitals, primary care physicians, specialists, and then of course the post-acute community. Delegate Pena-Melnyk, I'm not going to read the rest of your bio. It's online. I hope everyone does read it. She's just a remarkable woman, but I will turn it over to her.
Well, good morning. It is really an honor to be here with you. And first, I want to thank you for always being there every time I call you with an emergency, which is an emergency for me. You always reply, and I have a lot of respect for the work that CHRC does as the state HIE. We really rely on your expertise to guide our policy. So there's no need to read my bio. I'm just grateful to be here today and with all of you in this amazing panel and everyone that has decided to attend today, where you could have been somewhere else and you chose to be with us today. And this is such an important topic. So health equity is one of the major challenges we're facing in public health and healthcare and our society at large. When we experienced COVID for the last 2.5 years, we in Maryland, we have 23 counties in Baltimore City. And what we learn is that the county at the high of this pandemic with the highest number of COVID-19 cases was gorgeous Prince George's County, which is a county of majority African Americans and immigrants. Then when we broke it down, we found out that the zip code in the entire state of Maryland with the highest number of COVID was 20783, which is the immigrant community. So what did it tell you? The data told you clearly that the Black and Brown communities were the communities that were affected the most. And then we started to peel that like an onion and say, well, why? Well, because of all those social determinants of health. It is the way we live. I was helping families that were 9 and 10 people in a small apartment. If one got sick, they all got sick. It is the air we breathe and the way we, the way we live in these neighborhoods. It is not making enough money. It is the lack of education. So that zip code determines that health. So why and how are we able to address that with the data? So since my election to the House of Delegates more than a decade ago, my work has focused on using policy, and yes, I'm calling you, to shape the health outcomes and address the health inequities in Maryland. When my office gets a call about a problem, we take steps to find an immediate solution. After that, my staff and I reflect on how can we find a remedy to the problem at the policy level that we seek to identify and to remedy. So we seek the data to identify the system problems, we set the goals, and make evidence-based and impactful policy change. Because I'm able to do that. I can take a bill and I can impact the 6 million people that live in Maryland by policy, but the policy has to be based on the data. So more often than not, we find that the problem stems from a structural inequity that exists within our current public health and healthcare system, a public health system that has been underfunded for decades, that we addressed this session, which I'm so proud of what we did. So these structural inequities basically create an inequitable access to, as I said, education, transportation, housing, affordable healthcare services, and many other issues. The inequities in these these social determinants of health are often the root cause of the poor health outcomes that disproportionately affect communities of color, including, as I said, the impact of COVID, but also maternal and infant mortality, an emergency room visit for substance use, asthma, diabetes, and hypertension. The data shows us these. These health disparities have only widened throughout COVID, and it makes it clear that we must focus on addressing them. So in order to eliminate these health disparities, we must have access to quality, comprehensive, and actionable data on health inequities. It is the only way that I can convince my colleagues that this is a real problem, that you must respect the data, and that we must put resources into solving these issues. So when we introduce a bill and we see the fiscal note, and the fiscal note says that it's going to take $40 million to address, like the weight bill that I put in this session, for some of these waivers, or providing dental care for people on Medicaid, which we never did before, or expanding Medicaid to basically undocumented pregnant women that oftentimes end up in the ER the day they give birth, and it's the first time someone sees them, a doctor. They have not seen a doctor for 9 months. And that fiscal note says it's going to take $20 million. How do I prove it to my colleagues that it's worth the investment? Well, I do it by the work you do. Because we can see, for example, in the case of the pregnant, undocumented women, that last year, more than 5,000 of them went to the ER, and that we had to pay for that. And that it's worth the investment in prevention, because at the end of the day, we will save money, but we will also make sure that that baby is healthy and that mom is healthy. So that is because of the work you do. So your work really guides me and my colleagues. And what we did was, this session, we did a lot of that work, but we also did it the session before. So in 2021, we passed House Bill 28, Implicit Bias Training and the Office of Minority Health and Health Disparities. So the bill confronts racial inequity in the healthcare system through legislation that targets individual healthcare providers and the state as a whole. So at the systems level, this bill will strengthen access to data on how health disparities affect different communities by requiring the office to publish health data by race and ethnicity on its website. They will be used to provide evidence to create further legislation. The updated report will be published annually because we need to know what's going on. And it would include details about the health of people of color in the state and how it affects us. It will select information that will be updated every 6 months. This information would include the racial breakdown of residents covered by medical insurance, the ethnic and racial breakdown of medical personnel compared with the general population, and the racial and ethnic disparity in cases of dementia, cancer, diabetes, infant mortality, and other conditions known to affect minorities at a higher rate. Prior to this bill, the most recent data that we had on minority health disparities available on the Maryland Health Department website was from 2012. From 2012, that is unacceptable. At the individual patient care level, this bill will address implicit bias among healthcare providers by requiring evidence-based implicit bias training on a regular basis. Implicit bias, we know, plays a big role in perpetuating existing health inequities among minority communities. So the data that we collect will guide the bills we pass, and then it will guide how we budget and how we spend the monies at the state level. Another bill that we put in that I actually require Chris to be part of this basically commission is the House Bill 78, which is the Maryland Commission on Health Equity, the Shirley and Appealing Health Equity Act of 2021. And the bill established a commission composed of diverse stakeholders tasked with deploying a health equity framework. So we know we have at least 26 secretaries in the state of Maryland. And we know that those secretaries represent all the departments like health, like education, like transportation, and that the bill requires them to come together at least 4 times a year and to talk about their department and to create a health equity framework that will look at how their policies affect the people of color and the overlooked communities in our state. But it also requires the commission to basically inform its work. And what it does is the following. The first is it creates a data advisory committee that aims to provide recommendations regarding data collection and develop and maintain basically a health equity data for the commission. And Chris is part of that, which is a really important role that you play. And you know, Chris, you're so crucial. And for me, for Chairman Pena-Melnyk, the way I make decisions, because I feel that decisions have to be based, regardless of what you hear today, on data and science. Because it's important. Because once you have the data and you have the science, then you can guide the policy and you can say, well, I'm going to take that $20 million because that $20 million is going to make a difference. And your data tells me who goes to the ER, you know, how often, what kind of illnesses, what codes. It basically breaks it down, and you can see I'm excited at that level, which is so important to me because then I feel that I can be impactful in the way I legislate. And once there's better data, right, we will know who is not getting access to healthcare, and we can begin determining the reasons why. Once we have this data, we can develop policies and initiatives to solve these underlying public health issues, because the commission that this bill created has representation across sectors we can implement. And this is what's key, and why Chris and the work that all of you do is that we can implement targeted policies to improve all these conditions, whether it's housing, employment, food access, education. And since these policies will be data-driven, we'll be able to then what? Track the progress, see where it works. This is data guiding policy to advance health equity. It would not be possible without the support of information technology, which is so important. And I can go on about all the other bills that I have introduced, like the bill, House Bill 123, that Chris was an integral part of, that preserves telehealth, again, access in our state. And this bill, I also put in a bill, House Bill 1082, that creates a consumer health information hub requirement, which is, you know, addresses health literacy, because health literacy is so important. It is essential for our progress. So as I step into my role, which is a new role, I only have been in this new role of chair of the Health and Government Operations Committee for the last 2 weeks. I intend to continue to collaborate with our state designated health exchange, information exchange, in order to address the injustices that I see, to overcome the obstacles to health and healthcare, and most important in my eye, to eliminate health disparities, which I know, and I'm very confident because we're doing it, that we can do it through data. So thank you so much for having me. It's really a pleasure to be here with you.
Thank you, Madam Chair. I'm blown away by the different ways you're able to connect dots across the policy and then the actual disparities and issues that your constituents and that Marylanders are going through. I really appreciate your leadership and guidance. And it's a heavy burden you place on us as you ask for the data and technology, but we're thrilled to try and step up and meet your high bar. And we will hear a lot more about the Maryland Commission on Health Equity. I know Dr. David Mann has been a key role in that. But first, we're going to go to Mark Luckner, who is the Executive Director of the Maryland Community Health Resources Commission. He's been in that role almost since around when CRSP started. We've been friends going back at least that far. He's been in the policy space doing a lot in maybe an area that a lot of folks aren't familiar with. But Mark sits at a really interesting crossroads between the policy that the Madam Chair was just speaking to, and then really engaging with community providers and stakeholders to execute. And so without further ado, Mark, take it away.
Thank you. Thank you for that introduction, Craig. Craig, it's been great to work with you all these years, and you're a great friend. And before I talk about my remarks, I just wanted to congratulate Madam Chair. You know my personal connection to the Health and Government Operations Committee. I'm just very, very happy for you that you've been named chair by Speaker Jones. So congratulations to you.
Thank you.
A heavy burden, I guess. What I'm really humbled. You said it in your remarks earlier today, Craig. I'm just really humbled to be able to help implement some of the vision that you put forth on behalf of the Health and Government Operations Committee, and I'll talk about that now. So as Craig said, I'm the Executive Director of the Maryland Community Health Resource Commission. I started here in 2009, and I've seen a lot of great work here put forth by the Maryland General Assembly, and on behalf of the Executive Branch, we're happy to work on those bills. Let's go to the next slide. So our commission was created in 2005. I happened to work as the Chief of Staff to the Health and Government Operations Committee then to do a couple of things. First, to expand access to affordable, high-quality health services in underserved communities. Second, to support projects that serve low-income Marylanders, regardless of insurance status, and yes, Madam Chair, regardless of other factors that play into their access to insurance. And third, to build the capacity of safety net providers. These are folks like federal qualified health centers, local health departments, free clinics, behavioral health providers, really the backbone and infrastructure of our public health landscape that Chair Pena-Melnyk talked about a moment ago. Recently, and I'll talk about this in a minute, the General Assembly asked us to help implement the Maryland Health Equity Resource Act in the 2021, 2 sessions ago, legislative session. I'll talk about that in a minute. And then also in the 2020 session, the session that was cut short by COVID, the General Assembly passed what folks collectively call the Kerwin Bill, or the Blueprint to Education Funding. And that includes a new consortium on coordinated behavioral health supports, which is a conversation for a different day. But we'll also work with CRSP on that in the future. Let's go to the next slide. So I have a great group of 11 commissioners. You might consider us a state agency or a public health foundation. And I'll just give a shout out to my leadership of the commission. Former Senator Chair Ed Casemar is our chair, appointed by Governor Hogan, and our vice chair is Wayne Howard, who started the largest federal qualified health center on the shore. Great group of 11 commissioners that I get to report to. They're my board of directors, diverse in every sense of the way, in a good way. Let's go to the next slide. So the impact of the Community Health Resource Commission grants, just under 650 grants totaling $112 million have been pushed out into underserved communities by our commission, funding projects in all 24 jurisdictions. More than 500,000 Marylanders, most of whom have complex health and social service needs, have been served by these grants. And in the Relief Act that the General Assembly approved last year, we had a special project to help support the capacity of developmental disabilities providers. And that project, which resulted in 160 grants in over a 3-month period, served 16,000 individuals in that program. We're held accountable by my friends. Madam Chair is going to smile here. I'm held accountable by my friends at the Department of Budget and Management for how many grants are sustained after the funding is expended by our grantees. And so we're really grateful that more than 3/4 of those grants are sustained after our initial grant funding is expended. And the data that Chris provides plays a key role in that sustainability, which I'll talk about in a second. And then also, we're happy that our public resources help leverage almost $32 million in additional resources by safety providers, the bulk of which comes from private and non-profit local sources. Let's go to the next slide. So turning to the focus of our panel, and again, thanks for the invitation, Craig, to be on such a great panel. The Community Health Resource Commission and health equity. Look, health equity has been a long-standing priority of the Community Health Resource Commission for as long as I've been here. And that's reflected in the fact that when we do our annual call for proposals or RFPs, health equity is the top strategic priority set forth by our commissioners. We look to fund projects that address social determinants of health and really tease out that nexus between healthcare barriers, access, and vulnerable populations. Examples of these types of non-medical social determinants of health that impact underserved communities are lack of access to transportation, lack of access to health providers, food insecurity, and health literacy. And I'll just give a shout out to Madam Chair again for House Bill 1082. Really looking forward to helping that, that bill become implemented. Let's go to the next slide. So health equity continued. The Maryland Health Equity Resource Act, which was developed and approved by the Health and Government Operations Committee 2 years ago, has 5 policy objectives. And I'm reading straight from the bill. Number 1, to reduce health disparities. Number 2, to improve health outcomes. Number 3, improve access to primary care. 4, promote primary and secondary prevention services. And number 5, reduce healthcare costs, hospital admissions, and readmissions. That will sound very similar, Dr. Mann, to the prior Health Enterprise Zone initiative, which this bill really comes forth from. And I know Dr. Mann played a great role in that initiative from 2012 to 2017. We look to build on that work with this initiative. And Chris plays a huge part in that role, which I'll talk about in a minute. Let's go to the next slide. So we have, we put forth a call for proposals this past October, and we were thrilled with the response that generated 40 proposals requesting more than 30 million. And we've gone through a highly competitive call for proposal process, and Chris played a great role in that process. I'll talk about that in a minute. And now we have 9 grantees. You see that in the map before you, totaling 13.5 million, which are projected to serve more than 80,000 Marylanders. And Madam Chair, you referenced one particular zip code, 20783, in your remarks, and I'm just pleased to state that the proposal, the third bullet there under Prince George's County, from La Clinica de Pueblo, will be serving that same zip code. And so we hope that these 9 projects are responsive to the policy vision put forth by the Maryland General Assembly. These projects will start this spring, and there'll be implementation over the next 2 years. Let's go to the next slide. So our commission's collaboration with CRSP is outstanding. On the left-hand side of this slide, we work with our grantees, and in any given time, we have about 70 open grants. We routinize the routine use of CRSP reporting services by our grantees. These are many of which are primary care and other specialty care providers in the community. And that relationship with CRSP helps our grantees in documenting program impact, and then also in collecting data, frequently demonstrating that these interventions in communities with underserved resources, it shows that these investments in public health, in fact, yield reductions in avoidable hospital utilization, which then helps to promote long-term sustainability. On the Pathways to Health Equity program, the program that we're implementing right now, CRSP has a huge, it's not like Bernie Sanders here, a huge role in helping us implement this act. And that's why I was so thrilled when the Health and Government Operations Committee asked us to implement this initiative. My very first request in the bill was to be writing CRSP in to provide technical assistance, and CRSP has done that, and it's paid dividends. First, during the public comment period, when folks were giving us their comments about the initiative and developing their proposals, CRSP did outstanding work in preparing 2 public use data files for applicants. One, hospital data, and two, a social determinants of health data file that helped applicants drill down at the individual zip code level to look at the barriers in accessing care in their communities, and then tease out the specific health disparities at the individual zip code level. It was really cutting edge stuff. And I would just thank Craig and his team at CHRC for doing such outstanding work. Now that we're in the implementation phase for the 9 grantees, CHRC is providing technical assistance to our commission and the 9 grantees as they finalize the data measures that they'll be collecting to document program impact. And we had a call last week, a new grantee orientation call. CHRC was the star witness, if you will, in that call. And CHRC will be beginning weekly, every single Wednesday morning, technical assistance calls with our grantees and the commission. And so CHRC is really playing an important, vital role in our implementation of the Maryland Health Equity Resource Act. And we're just overjoyed to be able to work with Craig and his team. Very grateful to work with you, Craig, and very grateful to be on today's panel. And I'm happy to respond to questions after the additional panelist remarks. Thanks again for the invitation, Craig.
Oh, thank you so much, Mark. And I was just going to highlight the fact that because CHRC is getting so much data to drive kind of normal day-to-day healthcare and treatment at the point of care, it then enables us to repurpose the data, aggregate it, and make it available through programs like the ones Mark was talking about. So another quick pitch for the fact that having a central health data utility can be so powerful if leveraged appropriately. So Dr. David Mann, who's an epidemiologist at the Office of Minority Health and Health Disparities in the Maryland Department of Health, is also a member of the Data Advisory Committee to the Maryland Commission on Health Equity. And member might not be the right title. Dr. Mann's the one who brings all the data and expertise and tells us what's actually going on. He's lectured on the topics of health equity. He's written numerous books and papers, and we're really fortunate to have one of the preeminent kind of speakers and knowledge leaders on the topic right here within Maryland. So Dr. Mann, welcome.
Thanks, Craig. And since, as always, there's so much to say in so little time, I'm going to dive right in. The question of how does health IT promote health equity, to me, breaks down into 2 pieces. One is, how does data inform equity? And then how does IT enable data? So we'll talk a little bit about both of those items. So if we can go to the next slide. In the interest of time, I'm going to skip the outline because you'll see each of them as they come up. So next slide, please. So if you get nothing else out of this presentation, it's Dr. Mann's first rule of health equity data, which is any metric that is worth tracking separately by race, ethnicity, that's the short version, or by any other marker or characteristic that groups people who have either additional disadvantage or disproportionately worse health outcomes. So stratification, or some people call it data disaggregation, is essential because that's the analysis we absolutely have to have. And this is the answer to the question I get a lot, which is, how do we find a health equity metric in our work? The answer is, whatever your current metric is, just stratify it. So it's literally that simple. Next slide. So thinking about different ways we could use IT in health, we've got public health surveillance, which is the thing I mostly do, which I'll talk about primarily for the rest of the talk here. You can also use it in healthcare quality improvement. We can use it in resource allocation and planning. Where do we send resources? It can be used in clinical decision support. In an ideal world, EMR data would process through some smart AI and make some really interesting predictions about where we think someone will be in a certain amount of time. And some of our kind of risk formulas for things like cardiovascular risk are built on that kind of logic. And then another piece of IT that's not a purely data item is the role personal devices can have for pushing out communication and information to the public, or gathering information from the public, or as telehealth platforms. A lot of ways we can think of IT in the data space, in the healthcare space. Next slide. So I think as we're thinking about data and health, we want to do a crosswalk of purposes of data, which could be the public health needs assessment piece, or the healthcare quality piece, or the individual patient management piece, and then the various data sets that can contribute to that. So I've got a list of them in the first column. And then I've got a whole set of my assessments in the cells of which ones work for what. We don't have time to debate whether I'm right or wrong, but I think this is a framework to think about when you're thinking about data and health and how to link them up and make them work. And realize that inside each of these boxes, there's a need for an exactly optimal analytic to get the truth out of the data for that question. So we have to make sure we understand what the analysis design has to be in each one of these boxes. Next slide. So when I think about public health in general and health equity in particular, I see three roles in which we use data. One is a needs assessment step. We figure out who's got the problem, where is it located, how big or how bad is it, which subgroups are most affected. That's public health surveillance data primarily. Next step is we need to plan an intervention. So we need to understand the causes of the problem and the evidence-based interventions that we expect can fix it. And a lot of that comes from academic research data that gives us that evidence base. And where we locate scarce resources, again, gets back to the needs assessment step. And after we run the intervention for a while, we do an evaluation step, which is essentially repeating the kind of data we did for the needs assessment and see what's changed. And so if this looks a little like a plan, do, study, act kind of QI cycle, it sort of is. It's a little bit of a data do kind of operation. And so that's really what we do with data. Next slide. And then this is, I think, is a key slide because this is a kind of the causal mechanisms as I see them in terms of generating health outcomes in general and health disparities in particular. So on the far left, we've got a column of social determinants of health, and that was discussed at length by Chairman Pena-Melnyk. And you can see there's a long list there. A lot of those are different by place, and that's why place becomes so important. All these things cluster to give us differences in the prevalence of the causes of disease, differences in the severity of the causes of disease, differences in the access and quality of either prevention services or treatment services. And then those things move forward to change the frequency of disease or the severity of disease in a particular community. And those two things come together to actually give us our ultimate outcomes, such as death rates, disability rates, healthcare utilization rates like ED visits and hospitalizations, et cetera. So a disparity at any step in this causal chain marches through to the end and can either be attenuated by things that can reduce it further on, or can be multiplied by further disparities at further steps. Next slide. Next slide. So one of the challenges of the stratification approach I just mentioned is once you start disaggregating, you get tons of data. And this is why we need big data IT solutions. So this was me thinking about how hard it was to do COVID data when we first started doing COVID. And you can look here and say, well, we could ask, how do any one of 8 COVID outcomes differ by 7 different ways of organizing age, sex, and race, ethnicity, or combinations thereof in levels of geographic analysis that could have 5 different levels from statewide down to census tracts using 3 different metrics types, whether it's counts, rates, or age-adjusted rates, over 3 different timeframes. And so when you multiply that together, that's 2,520 analytic frameworks that you have to potentially choose among. And each of those analytic frameworks, for example, if you go to the census tract level, each of those analytic frameworks outputs 1,400 pieces of data, one for each census tract. So you can see how large the issue is and how this is really a problem for a really good IT solution, and certainly much more than one epidemiologist in the Office of Minority Health and Health Disparities can manage alone. It's got to be everybody's job in the entire state to do health equity data. Next slide. And this, I think, is my final final content slide, which just kind of gives an example of some of the ways in which it's complicated enough to need to do all these different things. So this looks at Maryland case rates at different points in time. And here in each of these charts, there's a line for the 4 major racial ethnic groups that we were able to produce data for. And you can see we also have kind of a gradient across age groups from the youngest to the oldest. And you can see that the relative levels of some of these different issues were different depending on what age group you were looking at. So it wasn't just enough to say, how do, say, Hispanics compare to whites? It's, well, how do Hispanics compare to whites in the same age group? Because that's a little different depending on what age group you look at. And then the differences that you saw across the age groups were different at different points in time in the pandemic. So you can see we started out with a significantly excess case rate for the Hispanic population. That continued, in the first 2 of the top 2 boxes there, but we see that they weren't the worst as we got later on in the pandemic at different stages. So in order to understand what's happening, we've got to have this really stratified analysis across a bunch of axes, because in fact, it is just that complicated to understand what's going on. So if I go to the final slide, which I think is my summary slide. There we go. So key things to take home. The key to equity data analysis is an appropriate stratified analysis. And data basically can serve equity and public health in general in the areas of needs assessment, intervention planning, and program evaluation. Health problems and health disparities travel in a causal chain from social factors to risk factors to disease frequency and severity to the ultimate outcomes that we're trying to control. And the complexity and volume of local data cross-stratified analysis will require big data IT solutions. And I'll be happy to take any questions in the question and answer session.
Great. Thank you so much, Dr. Mann. A lot to work through. Last but not least, we have William Henderson, who is the Principal Deputy Director of Medical Economics and Data Analytics with the Health Services Cost Review Commission. If you're not aware, and hopefully everybody is by now, but Maryland has a unique model through the Health Services Cost Review Commission that really has, we have levers that thoughtful policymakers and commissioners and stakeholders can pull to drive change and interventions at a rate and scale that really no other state can do. And William is one of the thought leaders behind that. And William, look forward to hearing your thoughts.
Thanks, Greg. Excuse me. William Henderson. I am Deputy Director for Medical Economics and Data Analysis at the HSCRC. I'll talk briefly first about HSCRC, but we could clearly take the whole time speaking just about that. And Craig stole my first point in that, which is really the Maryland model gives us a whole set of tools and responsibilities that, frankly, other states don't have. And I think there's a real opportunity we're trying to take advantage of, and we'll continue to try and take advantage to leverage that in the area of health equity. I think the fact that we have such a sophisticated health information exchange is a pretty significant degree in outgrowth of the model as one example of the way that I think the model has allowed us to work. But I think the next session is about the model, so I'm not going to spend too much time about that. Katie Wunderlich, our executive director, is on that panel, and you can join that if you want more on that. Getting specifically into what I do, so my center at the HSCRC is responsible for really our data shepherding and our data stewardship. And that takes two forms. And I'll try and talk to both of those and talk a little bit about how we're integrating health equity considerations into that. I think one of the things that the HSCRC is trying to do is really integrate health equity into everything we do. Because really every decision we make has a health equity component, and we're fooling ourselves if we don't recognize that. And a lot of times when you make bad decisions, it's because you haven't really thought about the equity impact, which could well be downstream of where you're operating. So in terms of the data, the first thing we do is we do a ton of data management and data facilitation, working with our hospitals, and then also working with our federal and state partners. So we're being focused a lot on a lot of very blocking and tackling things. Actually, I've spent a lot of time with CRISP over the last 2 years trying to make sure we actually understand who is Black and who is white when we look at our data. Clearly that isn't a clean distinction, but from the point of view of an equity analysis, we need to make a decision there. A lot of concerns. We have 7 different data sets, as David said. They all say the same thing. And in fact, actually, we found generally, yes, they do say the same thing, which gives us a lot of confidence going forward in the analysis we do off that. When you get into ethnicity, that's a different challenge. And I think that's the one we're going to have to look at more because, some people classify things differently, and then you have an other bucket, and the other bucket is a mess. So we're beginning to think about ways we can get consensus across our data sets and how we should think about ethnicity, because that really ultimately informs those metrics that then flow upstream. So very blocking and tackling things. Another area we spend a lot of time with CRISP, and I don't know that we've fully settled on, is those social determinants of health. For those of you who know claims coding, right, there's the Z codes, but they don't always get used. And should we be promoting their use, or should we be going down a different path? I think that's another area that's pretty rich for us in the coming years in terms of how we understand the data at a most fundamental level, so we can do that measurement and we can do that analysis that a couple of the other speakers have talked about. The second big area that my center gets involved with is what I would call sort of analytics facilitation. So sometimes that diving in and helping our centers understand the data they've got and how they use that. One area as an example of that is readmission rates is a big area of focus for the HSCRC. We've done pretty well against the nation, and that advantage has slowed a little bit in the most recent year. And so we're trying to get a better look into what are all the factors that play into readmission rates. And clearly one of those factors is going to be those differential issues in terms of Are we as successful in the wealthy population of the suburbs as we are in the economically challenged population in another area or in a rural population? Because, you know, I think the sort of the low-hanging fruit is probably stuff we've already taken. It's that more difficult stuff that we really need to be able to tackle if we're going to continue to be able to do better than the nation and do well for the citizens of Maryland. So we spent a bunch of time working with our quality team on additional data points that they can integrate into that analysis. Some great work done by Jeff Doherty and our team on the PI, which is a way of looking at readmission rates on an adversity adjusted basis to understand how we're doing across all populations. And we're also now digging into a bunch of stratification around race and age and so on in our readmission rates. The other big area for us, which is more indirect in the facilitation, is the funding we provide to CRSP and working with other organizations to promote various areas. There's a bunch of examples there of things we're doing. I think the one I'm going to pull out is Hilltop will soon or may already have be releasing a report through CRSP that was funded through an CHRC funding, which looks at the dual eligible population for Medicaid and tries to understand the data we keep from the nursing home and the long-term support services side and how that informs their readmission experience. And is there an opportunity to leverage that data that's locked in one subset of the healthcare ecosystem to inform another subset, the hospitals, in ways that they can work with those participants to avert readmissions on challenges that are sort of more subtle than what might normally come up in a hospital stay. So one of the findings of that study was around hearing, that people who have a documented history of hearing challenges have a higher readmission rate when they go into the hospital. You know, and that clearly sets up an opportunity to say, okay, can we leverage that information and help the hospital understand that situation and address it better upon discharge? And they identified about 4 or 5 metrics that were correlated with higher readmission rate, but were not classical clinical indicators. They were much more those social challenge type indicators. So we are looking at how we integrate that kind of analysis into the work we do, and really use our softer power, you might say, to promote factors like that. So I will stop there in order to allow some time for questions and turn it back to you, Craig.
Perfect. Well, thank you, William, and thank you all. We do have some chats going on, so please keep your comments coming, and maybe I'll take the prerogative to formulate a question around Medicaid data. So I think this might be a 2-part question for either William or Dr. Mann. I think the first, Tim Santoni asked if we should include Medicaid data in the list as a separate insurer. I think I might broaden that to be what is the role of insurers, both public and private, in some of these health equity reforms. And then maybe as a second question, we talk a lot about how we have all the data and CRSP is so wonderful, and I certainly never get tired of hearing that. But I wonder what if you could kind of wave a magic wand and fill one gap in data. What is the major gap that we should be pursuing?
So I guess on the gap question, probably the thing I'd most like to fill in as a gap would be to get really good social determinant of health data at the individual level that we can merge into the outcome data that we actually have a better handle on than the determinant data. In fact, that is the major challenge of the Data Advisory Committee of the Health Equity Commission, is to figure out how we build the health equity data set that is potentially a fairly complicated undertaking, and really is kind of about can we understand how the social determinants of health affect health in Maryland? How much impact does a social determinant have? And for a given unit of benefit of getting better or getting worse on a social determinant, how much better or worse does health get? If we can understand that, we can figure out which ones are the strongest impactors and which ones are maybe not as strong. And then which ones are more common and less common in Maryland, because if we know both of those things, we can figure out which are the ones that are really strong and really common. That's priority 1. And the ones that aren't really strong and aren't really common are kind of priority 4. In the middle, you've got the strong ones that are uncommon and the weak ones that are common. And you could prioritize things nicely if you had the data on the social determinants at the individual level. So that would be the gap I'd go for.
So Craig, I can comment on, if you'd like this type of a dynamic discussion,
Please.
I can comment on Dr. Mann's thoughts, unless you want to jump in, Madam Chair. Is that okay? Can I? So I referenced the enormous contributions of CHRC during the public comment period when we were soliciting proposals for the Pathways to Health Equity program. And I just wanted to reiterate the outstanding work that CHRC did in pulling together different data sources, which you might call social determinants of health data, that Laura Mandel and her team pulled from CHRC. And we put that out on a public website, which is still out there, that really helped applicants drill down to access what are the key barriers in each community at the individual zip code level, and then they could tailor their intervention strategies to help improve health outcomes. And we're hopeful that the 9 projects with CHRC's assistance will help collect both process and, more important, outcome measures to then show progress in those 5 objectives of the Act that was approved by the Health and Government Operations Committee. So that's one example of an ongoing project that we're really grateful that CHRC is having. My 2 cents, a gap, we're going to be working with the 9 grantees, which are from all areas of the state, and in some cases have multiple healthcare providers in a single program, right? Collect data at the individual level. And I know that we need to be able to provide access to policymakers in the General Assembly, showing that we're actually improving health disparities in specific targeted communities. And we will need to require or encourage grantees to collect demographic data to do just that. And I suspect, Dr. Mann, I know you remember the experience with health enterprise zones. That's going to be of tall order for these community-based programs to collect that data across multiple interventions and multiple programs, but it's needed for us to go back to the General Assembly to show the impact of the Maryland Health Equity Resource Act. So that would be that's what I'm sort of keeping me up at night, being able to have the 9 grantees collect that data and then come in full-handed, as it were, back to the General Assembly with that data.
Great. Thank you, Mark. Maybe to kind of further the conversation, we're hearing a lot about the data, but I know the 4 of you to be people of action, not just collecting data, but how do you actually translate data into positive results? We've gotten a couple questions around, the CMMI specific health equity bonus related to end-stage renal disease and a payment model. I wonder if maybe, William, if there are any specific payment models that you've put in place that you're hoping to drive specific action or maybe experiences of action. And then as a follow-on, it might be a related question for Chairman Pena-Melnyk. And how do you see broader community actors getting engaged? We're doing a lot with the healthcare system because that tends to be the levers we have within health data and healthcare policy. But there are many actors that can probably do more to generate equity and the kinds of outcomes we're looking for. So I'm curious about how you think about non-healthcare players in the space.
So I'll talk a couple of things. I think it is absolutely something we're looking at is wanting to build equity components into our policies. But I think we also have to look at the other way, which is, right, our policies have to be equitable. And it's sort of not a bolt-on exercise. So to talk to 2 things. One, I mentioned already that I think is really our pilot for how our quality program looks at equity is the readmission and the PI measure on readmission, which is a topic I won't really take a ton of time to go into, but if you look at the CHRC quality recommendations, it's discussed in there, but basically it tries to hold a hospital accountable, not just for improving readmission rates generally, which we want, but also closing the gap between readmission rates among less and more challenged populations. And I think that's really the model for what we'll be looking to do in our quality programs across the board. I think the other way to look at it is as we look at our policies broadly, how do they address equity? So right now, the policy that is had some initial drafts out there and is still ongoing is the revenue for reform policy. And what that policy really tries to do is say, if we look at how the revenue that the hospital industry receives under the global budget model is spent, is it being spent on population health initiatives that will ultimately promote good health outcomes and health equity? So we'll be looking to move that policy forward in the next few months. But that's really going to ask hospitals to document, have you spent some of the money that you retained under the GBR on policies in your community, whether that be a housing initiative or a food initiative? That is up to the hospital. But ultimately, we want to make sure that that money is being redirected in ways that invest in our future health. And I think really health equity is integral to the goals of that policy. So that's just a couple of examples, but I think those are good examples of the directions we're going in.
Great, thank you. And Chairman Pena-Melnyk, what do you think? How do we get other folks involved, or how do you look to engage other community partners?
I think that other community partners are important when you think about, for example, schools, social services, how we engage them. I think that we have to move towards a more integrated system, right, to improve the community health in our community. And I think that HIEs play an important role in that, to make sure that you partner and coordinate healthcare services with, social services, with school, behavioral health services, and others. The integration of services, I think, across the continuing of a patient's life beyond the healthcare system is an idea, and it should be the goal that we really want to, reach in order to address, as we have been talking today, these social determinants of health. So I think that everything is connected, and that we have to be creative, that we have to look at things in a holistic way and try to connect them, because they are connected. And if you connect them, then you can be more impactful as well. So it's important to bring people from the community and other players that you would normally not think of.
Great,
If I can
thank
make a
you.
comment on some of the intervention discussion. And before I get to that, just one comment about the Medicaid as an individual thought. Certainly all the individual sources, Medicare, Medicaid, large scale providers have the kinds of data that we often don't have in other places. Insurers often know more about your healthcare utilization than anyone else because they see everything because they have to pay for it somehow. So I think the insurers are very useful for both internal work as well as for broader public health work. But on the intervention space, I think we have to recognize that chronic disease, which is often what we're mostly talking about, is not managed in doctors' offices. It's managed in patients' homes. And so it's all about how do you get patients to be able to understand and execute a treatment plan that we spent all of that outpatient healthcare money designing and giving them in some kind of instruction booklet of some sort to take home and execute. So asthmatics have to do their asthma treatment plan, diabetics have to do their diabetes treatment plan, all that happens at home. And so when we do things that are trying to help that out, whether it's an asthma intervention or maybe something like the diabetes prevention program, we can ask ourselves on a program level, are we enrolling, say, minority populations in the right proportion? So pre-diabetes, 1/3 of adults have it. Most of them don't know it. Probably 40% of them might be Black or African-American. We're probably talking in the millions of folks who would need a DPP. When we enroll people in DPP, are 40% of them Black or African-American, or is it only 10% or 15%? So we can assess that. We can ask ourselves if we're enrolling at the right proportion. And if we're not, what's the intervention? What's the extra work we have to do to get the population that's most needy enrolled? And it will take more work because they have more barriers. And then when you get to the other side of it, so once they're enrolled, what results do they get? We'd like them all to lose 10% of their body weight. If half of the white population loses, but only 1/4 of the Black population enrolled loses, how do we fix that? Again, it's going to take more effort to get to the same level of result with a population facing more disadvantage. At the end of the day, too, if I'm assessing a community program like Director Luckner is dealing with, I can be very successful in the people I touch, but if I haven't been resourced to touch enough fraction of the population, all those improvements in my touched cohort won't budge the metric at the statewide level or the county level because I just didn't have enough reach. So a lot of considerations come in, not enough time to talk about all of it.
As usual, these topics seem to get more complicated the more you get into them. And I hear that there are no simple answers. Couple quick notes. We have a lot of comments coming in, and I really appreciate that. Our team is going to take them down and work with our panelists, both in this session and every other session, to follow up offline. We'll post answers, we'll post resources. So please, thank you for keeping the comments coming. Maybe just to go around the horn very quickly, in 30 seconds, what is the next thing that each of you is focused on? This is it's a mean question for 30 seconds, but what is the next thing that each of you is focusing on to hopefully at least make some improvement in health equity across the board? And we'll start, we'll go in the same order we started in. So let's start with Mark. Let's start with Chair Pena-Melnyk.
You can go with Mark, go ahead.
First, we're going to work with the 9 grantees to have a successful launch of the Pathways Health Equity Program. That's what we're going to focus on this spring and summer.
Perfect.
I think I would like to see integration of all the systems in Maryland. I think it's important to go cross-sector and bring everyone together, because otherwise we are going to be working just on our own without really being impactful. I like to see more connectivity in across all the systems, right? Whether you talk about the doctor's office to the hospital to the nonprofit in the community, more of an integration so that we can look at things in a holistic way. And I just started as chairman 2 weeks ago, but I'm pretty sure that I am not going to be shy. So I welcome ideas from you as well, where you think we as a legislature should be focused. We've done a lot of work that I'm very proud of, but we need to do a lot more, especially in the space of behavioral health. As you know, that's really important to me, and it's a topic that I care a lot about as we move forward.
Wonderful. And certainly the Maryland Commission on Health Equity, I think, is a very important first step into combining data and combining resources. Dr. Mann?
Yes, my main next step is wanting to get all of the non-health cabinet agencies in the commission to recognize their role and opportunity in health equity. And I think one of our keys is going to be that the Community Preventive Services Task Force has a guide to community preventive services that outlines a series of evidence-based interventions outside the healthcare system that have a positive impact on health equity that can be implemented. And I think trying to mesh those opportunities with the cabinet agencies outside of health and try to get everybody to find their role in the game is kind of where I see things going next.
Great. And William, you get the last word.
Yeah, I'm going to be a little bit redundant. I think Chairman Pena-Melnyk and David hit a similar one, I think, and I think it goes back to the point for this panel and the role of IT, which is, I think as a healthcare system, historically, we've sort of said, well, I'm responsible for what happens in an office, and outside that, I throw my hands up in the air and say, the social situation is bad. I think we need to change that mentality. Healthcare, ultimately, to be honest, is where the money is in some sense. And I think there is an IT opportunity for the healthcare community to reach out to those other services and say, how can we work with you, rather than sort of waiting for it to happen the other way around. So I think our focus is going to be, how we can work with CRISP and with our policy folks to facilitate that interaction across those non-traditional healthcare providers.
Wonderful. Well, thank you all. If we were in person, you would see the standing ovation start. But I promise it's going on. And I thank you so much for your time today and for your leadership throughout the state. Thank you.